Dr. Swanson. I'm just really excited to introduce Dr. Todd Swanson. He is an associate professor at the MD Anderson and at UTMB. He's an MD PhD and actually did his PhD in immunology of all things. And I have to say, Todd is one of our most talented and experienced radiation oncologists. He's an active member of the Brain Metastasis Clinic and honestly, one of the most progressive radiation oncologists I've spoken with. You will hear later today how important it is to do multidisciplinary disease management and deciding when to do systemic versus radiation versus surgery. And I've always appreciated Todd's input into that. Really excited that he's here with us today to share more specifically what the role of radiation is. And as you will hear, I would say radiation is an absolute mainstay for these patients and probably cures more patients than any of the other techniques. So thank you so much, Todd, and looking forward to your talk.
I'm very excited to be here today to help discuss the management of brain tumors, specifically radiation in the use of brain tumors. And I would like to share with you a presentation that I have to help orientate and give people an idea of what they might be going through when they have radiation. With that said, I would like to begin my presentation here. Once again, I'd like to share with you where we are with radiation. Can you see that moving now? The management of brain metastasis in melanoma patients has changed dramatically over the past few years. This has been catalyzed by the development of new therapies that show activity in the central nervous system, systemic therapies, a shift towards focal radiation therapy, specifically stereotactic radiosurgery, which I'll be spending a large portion of today's talk on. This is in full effect to aid in the preservation of neurocognitive function, and a movement to a more sophisticated radiation technique to help preserve neurocognitive function in patients requiring more comprehensive approaches, as is in the case of patients with numerous brain metastases. So the changes are really accelerating, and decisions based solely on guidelines may rapidly become obsolete. The optimal patient management then therefore requires close multidisciplinary evaluation and consensus. For that, we at MD Anderson have developed a multidisciplinary brain metastasis clinic that allows us to tailor approaches to when and how to treat brain metastases, and at the same time provide a forum for us as a group to evaluate patients for ongoing clinical trials. As such, the multidisciplinary effort includes the radiation oncologist, the medical oncologist, and the neurosurgeon, all working in concert with, once a plan is articulated by our group after evaluating patient in person, there is quite a bit of dynamics that occur afterwards between the radiation oncologist and the medical oncologist in terms of, once again, tailoring the patient for radiation versus systemic therapies. In a nutshell, radiation, people ask how radiation works. Tumors grow faster than normal cells do, but they do so with decreased fidelity. And therefore, when you insult them with something, which is in this case, ionizing radiation, the tumor cell is unable to repair the damage that is set into motion by radiation. So that damage could either be direct DNA damage, causing single-stranded breaks, which in those cells are incapable of correcting such errors, leads to cell death, or indirect damage, for instance, free radical formation, which then subsequently attack DNA, targeting the cell in the event that it can't repair its DNA correctly for cell death. There are, however, numerous side effects associated with brain radiation. In the short term, the radiation side effects are very similar to those that Dr. Ferguson alluded to in terms of those that are caused by the tumor themselves. In essence, radiation can cause brain swelling. This can cause nausea, vomiting, inflammation of the ear canals, which ultimately is a setup for an ear infection, changes in taste, loss of hair and skin changes, as well as fatigue. Long-term, the side effects include the persistence of any of these short-term side effects, as well as one of the most important things that most people worry about is impaired neurocognitive function. The side effects are not only related to the volume, but the location of the brain that is to be treated. One technique that is utilized often in our clinic is stereotactic radiosurgery. There are a number of radiosurgery platforms that people may come across in their treatment regimen, including gamma knife, a linear accelerator, which is really the workhorse of a radiation oncology for the treatment of all sites in the body with cancer. But in the event that it's used for stereotactic radiosurgery, there are a lot of other bells and whistles that are added to the machine to perform the treatment in the required specificity and sensitivity for brain metastases. A well-marketed linear accelerator is a CyberKnife, which is nothing more than a linear accelerated mounted on a robotic arm. And lastly, tomotherapy, which is it looks very much like a CT scanner, is outfitted with a linear accelerator to treat tumors both in the body and in the brain. At our institution, the workhorse for treatment of use of stereotactic radiosurgery in the treatment of brain tumors is a dedicated intracranial radiosurgery device known as the gamma knife. The gamma knife allows us to treat patients with sub-millimeter precision. It does so by targeting 201 radioactive cobalt sources, all converging at the site of the tumor. And this is what allows us to provide ablative doses to the tumor while minimizing tissue to the normal dose to the normal tissue around the tumor. At our institution, there are two ways in which we treat patients with gamma knife. This is the latest iteration of the gamma knife, the Elekta Icon. At our institution, we actually have two of these. On the side here is an imaging device known as a cone beam CT. We elect to treat patients either frameless, which is in a mask, as you can see here. It has a little dot that is placed on the patient's nose to monitor motion of the patient, in which if the patient moves more than a millimeter or so, we are able to stop the treatment and reposition the patient so that we obtain the most precise treatment for them. In those events in patients who have numerous brain mets for which lying still for the long treatment times, and or those patients for whom have tumors in very elegant locations within the brain, we work alongside of the neurosurgeon who mounts this stereotactic frame onto the patient's head, and this allows for extremely precise treatment as the patient is basically unable to move during the treatment. As Dr. Ferguson alluded to, it is unfortunate that we have no way of assessing the degree of resection at the microscopic level. One thing that frustrates all oncology providers is the fact that just because we can't see disease doesn't mean it's not there. And we indeed know that for patients who have had surgical resection of tumors, that they are without radiation therapy, they are at high risk of local recurrence in the surgical bed. It is therefore the standard of care to deliver radiation after a recovery period from surgery to the post-operative bed. This demonstrates that area that is being targeted here. The red area is that area in which the tumor was removed, and the green area is an extra margin that we put on because we know that there will be setup errors associated with our daily fractionation. In the case of post-operative radiation therapy, the radiation is delivered in 3 to 5 fractions to the surgical cavity. The preference for a linear accelerator to deliver post-operative radiation results from the uncertainties associated with the microscopic spread of disease in the area. And therefore, there seems to be at least some bias by some treating physicians to use a linear accelerator, which has less sharp dose fall off compared to Gamma Knife, such that we're able to provide some degree of therapeutic radiation in light of the uncertainties around the surgical cavity. There are unfortunate times, as Dr. Ferguson alluded to, that patients may have numerous brain mets. Although there is no absolute number to the absolute cutoff number to the number of brain metastases that can be precluded with radiosurgery, current practices is that more than 10 brain metastases warrants a more comprehensive approach to radiation therapy. This includes radiation therapy to the entire brain, or at least those parts which are identifiable with disease in them. There has been a movement in our field to spare neurocognitive function, even in the setting of having diffuse brain metastases. There is a paired set of organelles or portions in the brain referred to as the hippocampus. They look much like a seahorse on both sides of your brain. It has been shown that selective preservation of these structures during the course of whole brain radiation results in significant improvements in those patients who this area are preserved in, as compared to those who receive standard whole brain radiation. So when clinically appropriate, this is our method for treating whole brain radiation therapy in appropriate patients. You can see here that this is a dose distribution of radiation therapy given to patients with this hippocampal avoidance whole brain radiation therapy, selectively sparing, or the bluish area, if you will, on these paired bilateral organelles within the brain known as the hippocampus. This is as well given in conjunction with a Alzheimer's drug known as memantine, which has again been shown to improve neurocognitive function in patients undergoing whole brain radiation therapy for brain metastasis. I'd like to introduce at least one technique for which we are pioneering here at MD Anderson, and that is the use of brachytherapy for the treatment of brain metastasis. Brachytherapy is a form of radiation therapy by which radiation sources are placed close to the tumor, either directly adjacent or inside the tumor. Here is an example of a gamma tile, which is a surgical mesh for which there are small radioactive seeds that are impregnated in here. And this allows us to, with our surgical colleagues, to do surgically targeted radiation therapy, or START that provides immediate dose-intensive treatment at the completion of resection. You can administer high doses to surgical cavities with dramatic dose fall-offs, resulting in significantly less dose to adjacent normal brain. Although this is currently approved for use in recurrent primary malignancies and benign tumors, this type of approach is being pioneered here on clinical trial along with our neurosurgical candidates, for the placement of these radiation that deliver radiation from the outside in for patients, for select patients with brain metastases. So in summary, the advances in targeted systemic radiotherapy with systemic therapy with penetration into the CNS has delayed or abrogated the need for radiation to the brain in select patients. However, when radiation is required, stereotactic radiotherapy has decreased the exposure of normal brain to radiation while targeting tumors with high doses. In cases where whole brain therapy is needed, the use of sophisticated delivery techniques has demonstrated benefits in preserving cognitive function. Even in cases of surgical resection, radiation is still required for optimal local control. Techniques are being refined to further limit the dose to normal brain tissue while delivering therapeutic doses to the resected disease. Radiation therapy has an important and evolving role in the interdisciplinary management of brain metastasis. It provides techniques to help tailor individual patient therapeutic decisions so as they can continue their fight even in the face of the development of disease in the brain. Thank you very much.